Assalamualaikum and a very good morning, everyone. First of all, I would like to thank the organizer and also Boehringer who bring me here, inviting me to share a little bit of on health technology assessment in universal health coverage. So let me see, how do I control the slide? Is that my control?
Yeah.
Okay. So. I can move around. Yep. All right. I'll be like singer now. Okay. So I thought I have 20 minutes, and then I realized that it's getting shorter now by minutes now. So we try to be fast and quick so that then we perhaps would have a proper discussion later on. So I would talk about UHC and also sustainability. Just in short, I realized that a lot of those sustainability and UHC has been discussed with previous esteemed speakers. So I won't touch much, just to give a context of why we do need HTA in the universal health coverage. And I believe that this is a cube that everyone has seen many times again and again. Okay, all these dimensions about the 3 dimensions, who should be covered, the service that we are covering, and the cost that the proportion of the cost that will be covered by the pool fund. But unfortunately, most of the time, people only talk about 1 dimension, which is the U. They just talk about getting people as much as possible to be covered, okay, without realizing that they haven't given much thought on the adequacy of what they have to provide those things. They don't, perhaps these are the 3 that mostly neglected. And perhaps those who are already or embarking on universal health coverage find that they're having this problem, which I think reflected much in what been discussed by previous speakers. Number 1, adequate human resources. So you need not only clinicians, nurses and public health workers, adequate facilities that can provide essential drugs, equipment and other supplies, and adequate financial resource to ensure that everyone would have access to affordable healthcare. So the reality that we have is that even though we say that universal healthcare coverage is supposed to give everyone affordable access to essential care, but essential care, even at its most essential level, is not cheap. So essential service, for example, like HIV prevention and treatment, was estimated to cost average of $42 per capita in 49 low-income countries in 2009 and expected to rise $65 2015. I'm not sure whether this has been realized or not. But what they see is that in 2008, most of them only spend $31 per capita, and only 8 out of these 31 have a chance of reaching this $42, which means that there would never be enough to even provide an essential care. So how do we make sure that we can deliver the promise of universal healthcare coverage? So one of the things that we talk about is that sustainability. Okay, not only to make sure that the scheme is sustainable, that can continuously provide and deliver what we promise, but also to ensure that in that process, we are not jeopardizing other investment in the country. Because country is not about healthcare alone. We have a problem of education, we have problem of infrastructure and all that. So if we provide 100% of the national budget to the healthcare, so everyone else, education and everything else would deteriorate. So we want to make sure that whatever we have in healthcare coverage, in delivering UHC, is sustainable not only for healthcare, but also for the overall country's benefit. So one of the things that talk about, I think the previous speaker have touched a little bit here and there, is about trying to make sure that there is enough room in the government budget that allow us to provide what's being needed without jeopardizing our sustainability. So there are 4 pillars in the fiscal space in order to make sure that we can have enough room in the government budget to provide this service. Number 1, we try to get funding from external aid. So we get from the WHO, we try to get from Melinda Gates or Rockefeller, whatever, any donors that can give something. So maybe that can create, increase the budget. So number two is perhaps increasing the domestic revenues internally. Increase the government budget, how much the government or maybe the insurance or whatever that you can increase from your domestic revenue in order to make sure that this fiscal space can be increased. So, well, I see that I have a much lesser time now, so I'm not going to talk about everything. Okay? So, deficit financing is that when you spend more than what you have, and reprioritizations is what I'm going to talk about much later on, which is much related to the HTA. So I would touch a little bit on the physical space, one of the pillar, which is increasing the domestic revenue. And again, I think a lot of the speakers have been talking about 5%, 10%. I can understand a little bit here and there, but perhaps I need a clarification from the other speaker as well after this. I mean, how, because well, my Indonesian language is not that good as well. Okay. So, but what I can say is that there are evidence out there that shows a bit about how much benefit that you can gain from what you spend in the healthcare system. For example, in Chatham House, they say that every $100 per capita increase in government spending, under 5 mortality would fall by 13.2 per thousand. And this is actually quite a lot. Okay? So the more you spend, the better health benefit that you can gain. And out-of-pocket spending, which is one of the main driver of UHC, if you remember universal healthcare coverage, we actually try to say that we want to make sure that people would have access to healthcare without paying too much out of pocket. Okay. So out-of-pocket spending would only fall below 20% of total spending when public spending is around 6% of GDP. Okay. So I'm not sure whether is it 5% in Indonesia or not. So 3.6. Okay. Well, at least we have some work to do, isn't it? So, and also it was recommended, I think, that all countries should strive to spend at least $86 on health per capita. So this is again, people only look at how to spend, how to increase the revenue, But again, like what we see in the 4 pillars of the fiscal spaces now, this is only one of the way that you can look in order to make sure that you have enough fiscal space to support UHC. The other one is reprioritization. Okay, so here you see a graph that shows how much the country spends on health per capita, and together with their life expectancy. Okay, so you can see, just we take about here. Okay, so as you can see that for the amount that you spend, there are actually, some countries actually can obtain higher level of health for the same expenditure. So we spend, for example, like here, they spend about 100 here. Okay, so there are countries that can gain a longer life expectancy compared to those countries who spend the same amount but actually have lesser life expectancy. So it means that there is a possible room to create efficiency in the system. Okay, so here, as you can see as well, okay, the star here shows that perhaps the spending in healthcare, okay, in some of the countries. So this same amount of spending, because you spend here, it means that you can only stop until here to provide the service to the countries. Okay, so all of these are, some of these are HIV service, diabetes, and all that, all the healthcare service. But if your country is spending about here, which means that you are paying too much, and you have to stop until here and provide the service, not enough, because if you actually, for that same amount that you spend, you can actually increase the service that you provide to the countries. Okay, means that again, if you can create efficiency in the system, you can reprioritize which one would give the better health benefit at the lowest cost, then you can gain more in your physical space. So how does countries do in their process of reprioritizations? So these are three of the most common methods. One, they cover only certain group first. For example, like formal worker. Okay, so only they will start with formal worker, and then those with then the informal worker, those who are not registered in the revenue or in the government system, that will be covered later. Okay, some of the countries took this approach. Another one is cover everyone but limit the range. They don't want to give everyone or unlimited range of the medical benefit. Okay, for example, like they just say, we will start with inpatient service first, and then followed by outpatient, covering outpatient. Okay. Or sometimes you also see that some countries also have cover most medical treatment, but not non-clinical. Okay. So, for example, like, well, they only cover the medical treatment, but not the public health or perhaps the surgery. And sometimes they have, in order to do this, they have a waiting list. Okay. So, waiting list is prioritized based on who comes first then. Okay. But as you can see, this is a prioritizations that we made. But who decide that formal worker should be covered first compared to informal worker? Who decide that inpatient should be covered rather than outpatient? Who decide that a certain treatment for a certain specific disease should be used instead of another one? Okay. How do we decide that? How do we decide who and what and when should have the priority? Okay. So all this while, most of the government, most of the authorities, they decide perhaps on a whim. Okay. And it happens quite a lot actually. Even, I'm sorry, I think I panicked with the 2 minutes 52 seconds I have now. Okay. So most of the countries, sometimes you see that even in the developed countries, they just based on the politicians. Elected today, at night he has a dream or a nightmare, tomorrow he announced something. Everyone should have this, everyone should have that. Okay. So, but then, the problem is that when he said that, it's not based on perhaps on some rational evidence finding. Okay. So for example, if they say that, suddenly they say, okay, today every hospital should have a cath lab. Okay. So even though it's a good thing for cardiovascular, but then the money that you put in the cath lab is actually taking the money from somewhere else. You're taking money from the diabetes, you're taking money from the public health, perhaps, in order to fund this policy, new policy that you have without even thinking properly. Okay. So this is where HTA comes through. HTA is a process where you combine all the best available evidence, including from the country's aspirations, so that then you can provide the recommendation based on that. Simple as that. Okay. So the reason is why we need this HTA. I'm going to give a little bit faster now. Okay. Well, number one, because we want to have evidence that can perhaps improve our efficiency by perhaps improving the practice variation. Most often, sometimes we see that people go to, with the same condition, to a different, will receive a different treatment from a different practitioners. They go to clinic A, they receive a treatment A. They go to clinic B for the same condition, they receive treatment B, and so on. So this is a huge practice variation, which perhaps does not really provide the most efficient treatment for healthcare. And here you can see that this is a study done by Appleby. So they shows that the greatest variation across all the treatment being provided. I have a few more seconds. I'm going to be double faster now. Okay. So we also try to make sense of evidence because there's a lot of evidence. I mean, now we have 75 trials and 11 systematic review, which actually generate a lot of evidence. How can we say that one practice is better than the rest? So, and also there's a lot more of technologies nowadays. This is from in Malaysia. So in Malaysia,
every year we would have about 30 to 40 new drug entities applying to be included in the formulary in Malaysia. And I think this is perhaps what you have discussed about the finite budget and resource constraints, but what I'm going to focus next is how is this HTA being used now. So HTA is currently being used where we have a process where all this scientific evidence being assessed about whether they have bias or not, and then based on this assessment of this evidence, then you took the value from the society, combine it with this evidence, so that then you can help to decide whether should recommend or not recommend a specific technology. Okay. So in many of the countries, HTA now has become institutionalized, where you have a specific agency being established that can provide a recommendation, can do all the process that we discussed just now, appraisal and also assessment. So some actually ask the applicants, mostly the industry, to give dossier that to be appraised and assessed by a HTA agency, and then a reimbursement committee would decide on it, or there are some who actually establish the assessment and appraisal in the same agency and do it on their own. Okay? So across the world, this is some of the summaries that I would have. There are a lot of investment. I mean, you can see the huge disparity here. The UK spent 21.6 million per year to support their agency. Germany 1.5. Malaysia, well, undisclosed, is under the Secret Act, okay. But HTA committee in Indonesia, I'm not sure whether this is correct or not at the time, okay, it's 0.1 million US dollar, okay. So again, this actually reflects the capacity of perhaps what the agency can be expected to do. We cannot expect them too much to do with just a minute capacity. So what happened now is that we see that across, even in Asia, there are some countries which is well established, well resources, and they're actually capable to do many things. Okay? They can be able to provide a full assessment, a full appraisal of the technologies that comes through for the reimbursement, but some countries is perhaps struggling, okay, in order to catch up with the capacity expected by them from the government and the society. So the challenge that I see, I think I'm going to skip this one, just to show this one then, that in order for HTA to be properly used, we rely on evidence, but unfortunately sometimes evidence is not there. Okay. So, and some of the evidence that is there, it have a poor study design and reporting. Okay. So HTA, health technology, is not only limited to drugs only. So it can only, you can also go to whether should we a specific service, a specific policy. Okay. So there is also inconsistency across studies, and some of these studies rely on a surrogate rather than a patient outcome, and also some of the studies also would have an inadequate line of follow-up that might not be able to inform a proper HTA. So and HTA actually needs a lot of resource. Okay, so a lot of the review that we are doing now, minimum on average median is around 6 to 16 articles. So you need people to read and able to assess and appraise all that kind of evidence. Okay, so low-income countries, even though they are actually the one who most needed this HTA to reprioritize their healthcare, but unfortunately they do not have the capacity to do one now. So with that, there comes the networking. Okay. So there are a lot of agencies nowadays, or institutions, organizations that are supporting HTA regionally and globally. So there is a HTA Link organization which I represent as well in Asia. Okay. So there is the ISPOR, there is the HTAI, there is the INATA. So, and also some of the foundations like Bill Melinda Gates and Rockefeller are actually creating a lot of the networking opportunities for all the agencies, so that then you can actually share the evidence between one another. So with that, I would like to thank, I'm sorry for taking a bit of time, but I'm really open to questions after this. Thank you.